Before we begin, I introduce myself, greet the patient, and explain the examination. I'm observing the patient's overall appearance. He seems generally well, not emaciated. His posture seems normal. I don't observe a stooped forward position like we might see in respiratory distress, specifically COPD. The patient is not breathing through pursed lips, and I'm not noticing any strained facial expressions. I'll begin the formal assessment by measuring heart rate and rhythm. I'm going to flip the patient's forearm so the palm faces up. I'll use 3 fingers to assess the radial pulse. Rate, rhythm, and strength are all normal. As I was assessing the heart parameters, I also assessed the respiratory rate, rhythm, depth, and effort. Rate is around 16 breaths per minute. If we saw tachypnea here, that could signal something like restrictive lung disease. Rhythm is normal with evenly spaced breaths. Depth is normal. I see appropriate chest expansion with each breath. And effort is normal. I don't see any involvement of the accessory muscles. Now I'm going to check for clubbing, which occurs in arterial desaturation because of lung or heart disease. I'm seeing a normal 160-degree angle. I'm also noting the absence of nicotine stains on the patient's fingers. Before we rule out clubbing, I'll check for sponginess and softening of the tissues around the proximal nail fold. This can be an early sign of clubbing. Let's check for a flapping tremor. I ask the patient to raise his arms and flex his wrists to 90 degrees. While we didn't do it in this video, we should push on the fingers to see if they flap in response, which would indicate hypercapnia. Now, I'll look for signs of both central and peripheral cyanosis. Central cyanosis indicates arterial hypoxemia and presents as visible blueness of the lips, nail beds, oral mucosa, and conjunctiva. Peripheral cyanosis, which is seen in the earlobes, nose, fingers, indicates poor peripheral blood flow due to vasoconstriction. Finally, before we move on to the posterior chest exam, I will check for pitting edema, which could indicate something like congestive heart failure. Now we will move on to the posterior chest exam. I ask the patient to turn with his back toward me. I'd like to note that there's no indication of vertebral anomalies, like kyphoscoliosis, that would restrict respiration. I'll begin by palpating to identify tender areas which may indicate a fracture or inflamed pleura. I ask the patient to let me know if there's any discomfort. Chest wall expansion. First, I need to count ribs. I'll ask the patient to cross his arms with his hands on each opposite shoulder and tilt forward. I'm starting at C7 and sliding down. Asymmetry in chest expansion could indicate fibrotic lung disease, pleural effusion, lobar pneumonia, and so on. This also gives me the opportunity to assess the spinal curvature more closely. While mild kyphoscoliosis may not significantly affect respiration, severe cases can lead to impairment of respiratory muscles, upper airway obstruction, and eventually respiratory failure. To check expansion, I'm placing my hands with thumbs parallel to the midline at the 10th rib and raising the skin fold. I instruct the patient to breathe in and out through his mouth. My thumbs are moving laterally equally, about 2 centimeters on each side. I'll check tactile fremitus or chest wall vibrations, which gives us information about the density of underlying lung tissues. I'll ask the patient to say 99 repeatedly each time I touch a different place. We see decreased tactile fremitus in a range of conditions: COPD, pneumothorax, pleural effusions, and increased tactile fremitus usually indicates consolidation in pneumonia. Now percussion. We normally see resonance over the lungs, and hyperresonance can indicate emphysema. It's dull once we reach the diaphragm around T10 and dull higher up in conditions like pneumonia and pleural effusion. I'm going to percuss beginning at the suprascapular region, where we see the apex of the lung, and move down in a ladder pattern. I'm comparing each side and also noticing differences in percussive notes as we descend toward the level of the diaphragm. Before we finish with percussion, I'll assess diaphragmatic movement. I'll instruct the patient to exhale deeply and hold while I percuss to the lowest level of resonance on the right side. I'm marking that level. I advise the patient to breathe normally for a moment once I've marked the point of dullness. Then, I'll ask the patient to inhale deeply and hold, and we'll repeat the same procedure. Using a ruler to measure the distance, I'm seeing a difference of 4 centimeters, which is within the normal range. Before we auscultate, I ask the patient to cough to clear any secretions in the airways. I'm auscultating in 14 posterior locations. I instruct the patient to breathe in and out deeply, mouth open. I'm listening for normal breath sounds as well as adventitious or abnormal ones. I listen at each location for 1 full cycle. Near the scapula, I heard bronchovesicular breath sounds, which are moderately loud with an intermediate pitch. Everywhere else, I hear vesicular breath sounds, which are soft and low-pitched, with a longer inspiratory sound. I do not hear any adventitious lung sounds, like crackles, wheezes, or rails in our patient. However, had they been present, these sounds could indicate a range of conditions, including bronchitis, asthma, or pneumonia. As I proceed through this examination, I'm advising the patient to take normal breaths in between to prevent lightheadedness. I ask the patient to lay supine for the anterior chest examination. To begin, I'm asking the patient once more to tell me if he feels any discomfort as I apply pressure. I am also watching for wincing or signs of discomfort in his face. To assess chest wall expansion, I need to count the ribs, starting from the suprasternal notch. I slide my finger down 5 centimeters to feel for the bony ridge of the sternal angle. Then I move laterally to the second rib and count downward. Then, I place my hands horizontally and my thumbs parallel to the midline while raising the skin fold. I ask the patient to breathe in and out deeply. I'm looking for symmetric expansion and specifically looking for the bucket handle movement or change in transverse diameter of the chest wall with respiration. Similarly, I place my hand flat over the sternum and ask the patient to take a deep breath. I'm looking for an increase in the anteroposterior diameter or pump handle movement. For tactile fremitus, I begin in the supraclavicular region where we find the apex of the lung. I ask the patient to say 99 each time I touch a different place. The premise is that sound vibrations are conducted better through solid or fluid than air. An excessive of air will decrease tactile fremitus, while inflammatory exudate, for example, will increase tactile fremitus. For the anterior examination, I percuss 6 positions bilaterally. All of the lung field should be resonant except the cardiac dullness, which is in the 3rd to 5th intercostal space, around 6 centimeters lateral to the sternum on the left, and the liver dullness near intercostal space 5. Dull percussive sounds outside of these areas could indicate abnormal lung density, like we would see in atelectasis, tumors, pleural effusion, or lobal pneumonia. There's also an area of tympany at the stomach air bubble. If I heard that tympany in the lung field, I would suspect a diaphragmatic hernia. I ask the patient to cough once more and proceed to auscultate the same 6 positions bilaterally. I ask the patient to breathe in and out deeply with his mouth open. At the trachea, I hear the tracheal sound, a high-pitched, loud, harsh sound that's equal in both phases of breathing. As I move over the manubrium, I hear a high-pitched tubular bronchial sound with a shorter inspiratory period. Between the first and second intercostal spaces, I hear a combination bronchovesicular sound that is tubular and rustling and equal on inspiration and expiration. I'm moving around the lung fields and staying in each place for 1 full breath. Here, we hear vesicular sounds, which are soft, relatively low pitch, and have a longer inspiratory period. I'm also listening for adventitious or abnormal breath sounds, like stridor, which is heard over the trachea, and wheezes, which we would hear in the chest. This concludes our respiratory examination.